Hello and welcome to Biological Treatments for OCD. What we're going to look at in this session is the sort of treatments we might propose if we adopt a biological approach to explaining OCD. Specifically, we're going to look at SSRIs and we're going to evaluate the efficacy, that means how effective they are, as well as the potential limitations of such treatments. So, before we start, let's have a quick recap of the biological explanation of OCD. So, OCD consists of obsessions and compulsions. There seems to be evidence of a genetic link, with monozygotic twins having an 87% concordance rate for the symptoms. That means that if one twin has it, the rate that the other twin will also have it is in 87% of the cases. However, they're not 100%, so we can't say it's purely genetic. There are two genes that have been identified specifically, and those are the SERT gene and the COMP gene. The COMP gene is responsible for influencing dopamine levels, and the SERT gene is responsible for serotonin levels. And we talked about these last time, how too much dopamine might enhance the rewarding aspects or anticipation of reward from the compulsive repetitive behaviors. And serotonin, by having lower levels, means that the system is over anxious. Neurological structures and activity within them was also highlighted in two particular areas, the basal ganglia and the orbitofrontal cortex. And then we looked at the evaluations of this explanation. So let's get started on treatments. SSRIs, selective serotonin reuptake inhibitors. So as we just said, low levels of serotonin have been associated with OCD. That suggests that to reduce the symptoms and make them less prominent, all we would have to do is increase the level of serotonin. And this is at the level of the synapse. This would increase the chance the serotonin would then bind to the postsynaptic neuron and have an action upon that. In this case, serotonin has inhibitory effects in most cases, and therefore is likely to have an overall calming effect on neurotransmission, on synaptic transmission. So how does the SSRI work? Well, here we have a synaptic cleft or gap, and we have a few things worth noting, like a mitochondria, a vesicle containing neurotransmitter. In this case, we've got the synapse, the postsynaptic receptor, reuptake channel, exocytosis, and a recaptured neurotransmitter. Now, this is the presynaptic neuron, and the action potential is traveling along the axon of the presynaptic neuron. When it gets to the end, it stimulates the release of neurotransmitter, in this case serotonin, from these vesicles where it's stored, and then it diffuses across the synapse and binds to these receptor sites on the postsynaptic neuron. Now, what normally happens to serotonin when it's in the gap is it'll either be broken down or reabsorbed into the presynaptic neuron. However, by taking SSRIs, we block those reuptake channels, and that means that there is less neurotransmitter being scooped up from the gap and back into the cell. In other words, it increases the amount of serotonin in the gap, therefore increasing the chance that molecules will bind to the postsynaptic neuron and have an effect. SSRIs then have an overall effect of elevating serotonin levels. Evidence for this came from Thorin, who found that an increase in the levels of 5-HIAA in the cerebrospinal fluid, this blue area on the diagram here, was found in people with OCD. Now, 5-HIAA is a metabolite of serotonin. When it breaks down, we find this as one of its compounds. High levels mean more serotonin is being broken down than in a normal brain, and therefore, high levels of 5-HIAA means low levels of serotonin. Brilliant. Cerebrospinal fluid, as I said, your brain is sort of swimming in this fluid, except there's not much room for it to front crawl. What evidence is there that this would work? Well, Kellner, 2010, suggested that in 40 to 60% of the cases, patients with OCD present with minimal symptoms. So that's a significant improvement in 40 to 60% of the cases. Kobach conducted a meta-analysis finding that behavioural treatments such as CBT were more effective. Foa et al. 2005 found that CBT was significantly more effective than SSRIs. However, SSRIs were still better than placebos. So if we're doing a cost-benefit analysis and you think about how expensive therapy may be, SSRIs still work, they just don't work as well as the therapies. So another downside to the SSRI proposition is side effects. And this graph really shows you, this table shows you the frequency in just one study of specific symptoms, side effects from it, from relatively minor dry mouth to sexual dysfunctioning and tremors and shaking hands and things like that. Right, tricyclics and anti-anxiety drugs. So SSRIs work primarily by elevating serotonin, and they're mainly used as antidepressants. Well, tricyclics can also be used. Drugs such as anafranil, I think it is, block the transport mechanism by which serotonin is reabsorbed. So it has a similar action to SSRIs. This has the effect of increasing serotonin and noradrenaline levels. However, tricyclics tend to have more side effects, and they're usually used as a secondary treatment when SSRIs either haven't worked or can't be taken for some reason. So generally speaking, these tend to be used as secondary treatments when SSRIs haven't worked for some reason. Maybe you have the side effects are too severe, or you cannot take them for other reasons, so they're then prescribed, but they're not often a first port of call. Anti-anxiety drugs then. Well, OCD is an anxiety disorder, so we can use benzodiazepines. These are drugs such as Xanax, and they can be used to treat OCD. They work on the neurotransmitter GABA. GABA has a generally quieting effect on many neurons, and so increasing GABA increases the quietness. That's the wrong way of putting it, but reduces the general activity. GABA binds to the postsynaptic neuron, and this prevents other neurotransmitters from binding to it. So whereas increasing serotonin means that more serotonin will bind to the postsynaptic neuron, but that's okay because serotonin has this calming effect. GABA just acts as like a blocker, and it's just going to stop anyone from getting in, especially if they're the sort of neurotransmitter that might trigger an action potential. I don't know why I'm doing that with my head. Essentially, neural activity is slowed, and this results in feelings of relaxation. Alright, some other evaluations then. Symptoms are often minimalised by successful treatments, but they're not eliminated. And the disorder itself may still be prevalent as soon as you stop taking the drugs. The improvement rate is 40 to 60%, but that also means that 60 to 40% do not respond to the treatment. So SSRIs are not a universal panacea to treat OCD for everyone. Treatments tend to be slow acting, they require months, and we're not sure why, because actually after immediately taking SSRIs, you have more serotonin available, potentially, but it takes months and months for the positive effects on your OCD to be seen. And there is a high relapse rate and issues for treatment. So Simpson suggests relapse rates may be as high as 45% compared with only 12% for psychological interventions. Another issue, which is quite a meta issue, it's quite a big issue, it was raised by Turner. Turner criticises this approach for publication bias. And what Turner means is that when you look at the number of papers on SSRIs that are published that show positive results compared to those that show negative results, more positive result papers are published. So there might be, if we carry out two studies, you carry out a study and I carry out a study, I get a positive result that shows that SSRIs work, you get a negative result that shows they don't. My study is more likely to be published, according to Turner, than yours. And this will lead to a distortion in the field in terms of how successful these treatments are seen. The final thing to mention then is the randomized controlled trial. This is the gold standard for science. This is one of the most important methods that we use to find out if drugs actually work effectively. We take a group of patients that are controlled for on some variable or variables. They're randomly assigned to either the treatment group or the control group. Both groups are followed up and we compare the results. So if you were given the drug, SSRI, and you showed a positive improvement, we would mark that. If you were given the drug and you were not given the drug, we monitor that as well. To avoid investigator effects, we use a double-blind study. That often means that the doctor or experimenter and the patient are both unaware what trial that particular individual is in. That's easy with a pill because you just give half sugar pills and the other half the actual medication, and the doctor doesn't need to know which ones are which. So that's all we've got for treatments. I hope you have taken something away from this lecture, and if you have any questions, as always, you know where I am. But thank you very much for your time, and I will see you later.